One of our very favorite booths when we are in Central Park is Ask the Healthcare Expert booth. And today we have our virtual version of that booth. We have obtained questions from the community. We have Dr. Jeffrey Wertheimer, who is the head of clinical neuropsychology services at Cedars Sinai Medical Center in Los Angeles. Dr. Wertheimer, we have a question from Mary. What is the best way to respond to someone with Parkinson's when he or she is talking about a hallucination they are having? Do you recommend going along with what they are saying? Or should you say you don't see what they are seeing? Or is there some other advice that you have? It's a very good question and a very challenging question.
Mary, what a great question. So thank you for asking me that. The topic of hallucinations can be difficult to discuss for some individuals, if not many. So I often recommend having an empowering conversation or an open dialogue about hallucinations, because hallucinations can bring about uncomfortable feelings of isolation, feeling embarrassed, or even feeling scared for many, both people with Parkinson's as well as those who share their lives. Importantly, I recommend inquiring as to what extent individuals are bothered by the hallucinations and what the hallucinations may mean to the individual. So many of the individuals with Parkinson's are not bothered by their hallucinations. It's even more troubling for the family members. So I often ask them how they would want you to respond should they be having those hallucinations. In other circumstances, though, some individuals are quite disturbed by the hallucinations, and support and redirection or other intervention may be necessary. So to answer your question, Mary, I do not recommend going along with what they're saying. Rather, based on the preference on how to respond, I recommend providing emotional support, validating their experience when they see something that other people can't see, and then providing that reassurance and redirection. So as many feel alone or helpless in such experiences, I do encourage the communication with the treatment team as well, the movement disorder specialist, for example, because again, sometimes interventions needed, medications, or even working with a mental health provider can be helpful in addressing those concerns, or at least just getting that reassurance from the treatment team can provide at least some level of support that other people may not receive.
You know, it's interesting, Dr. Wertheimer. I think some of the challenging part of that question is that it is okay with some people. I have known some people that see little pink rabbits or certain people, and they're fine with that, and they are okay. And sometimes it's just as hard to understand that part as it is the other side of it.
Exactly.
Our next question comes from Paul. Since Parkinson's has so many varying symptoms, and these symptoms can be heightened by certain medications, why doesn't the medical field consider Parkinson's as severe a sickness, as heart disease, diabetes, or some other disease?
Paul, I can understand why some may feel that way. While there's ongoing need to educate the medical and general community about Parkinson's, importantly, there's been an impressive effort to heighten awareness about the complexity of PD, both as it relates to motor symptoms and non-motor symptoms. And as you pointed out, there's this intricate understanding how medications may affect symptoms, as well as just how symptoms may fluctuate. So individuals today still remain unaware about Parkinson's in the medical community, particularly as it relates to medical symptoms, psychological symptoms, and the social challenges they're related. So there may be more familiarity with heart disease and diabetes, among other medical conditions as you bring up. And intervention-based products and the media may heighten the visibility to those other syndromes or medical conditions. But importantly, I would say our role at this point is to continue our advocacy. We know that Parkinson's disease may not directly cause death, or it's not a condition that will present with imminent risk of death, but the condition does remain serious and warrants a lot of attention, and coming together as a community will help to accomplish that visibility and further education to our medical community and the community more broadly.
Excellent point, Dr. Wertheimer. Advocacy is so important. So very, very important. Our next question comes from Julie. Does Parkinson's affect the ease of a person, female, to climax during sex? Never had a problem in 37 years of marriage. but the last 6 months nearly impossible to climax. Sex feels the same, and it's very wonderful, just extremely difficult to climax and can't most of the time, and wonder if this is normal.
Thanks for asking the question, Julie, and I laud the ability to ask such a question because, as we know, sexual health is not always easy for people to discuss. To answer your question directly, the neurochemicals that change with Parkinson's can have a direct impact on sexual function. I should say, when it comes to Parkinson's, diminished sexual function is very common, from lack of sexual desire to low sex drive to difficulties with orgasmic functioning. The chronic progressive neurologic disease can impair sexuality in one way or another. So what we highlight is often the importance of discussing sexual health. And it may be awkward, as I mentioned, but such a conversation can be very therapeutic for the individual, if not the couple. So I'd recommend speaking with a therapist familiar with and trained in addressing sexual health, and most particularly someone that's knowledgeable about Parkinson's disease or other neurologic conditions that may impact sexuality.
Excellent. I think we need to thank Julie for that question. There are probably people that are going to watch this video and think that they've had that question for a long time, but were afraid to ask either their doctor or someone else. So you probably helped answer that question for a lot of people, Julie, and we thank you. The next question comes from Sandy. My husband has a great deal of difficulty with sleep. He gets up several times during the night and says he can't find a place for himself. This is often accompanied by pain in his arms, which go away. It goes away when he gets up. Do you have any recommendations?
Sandy, what a marvelous question. And I'm going to seize the moment to even say sleep disturbance is one of the most common non-motor symptoms discussed in our clinic. So let me highlight this point. Generalizing the question to all of our audience today, I'd say, is let's highlight that there are many causes of sleep disturbance in Parkinson's. So the first recommendation I have is to understand what contributes to the sleep disturbance and then tailor the treatment to the cause of the sleep disturbance. For example, is it the need to urinate, a term we call nocturia? Is it a pain due to Parkinson's, or is it a pain due to another medical condition that disrupts sleep? Is it restless leg syndrome, that irresistible urge to move one's legs? Circadian rhythm disruption is common. Does one have another sleep disorder or sleep disorder like sleep apnea? That's where we have lapses in breathing. We have REM behavioral sleep disorder, which is very common in Parkinson's. That's when sleep disorder may show itself through acting out one's dreams, I should say. Also, sleep disturbance may be caused by depression, anxiety, or even some sort of restlessness, internal or psychological. So the second recommendation there is to meet with your movement disorder specialist or even a sleep specialist that is knowledgeable about Parkinson's, because some sleep disturbance may require pharmacological or medications. But importantly, some sleep disturbance may benefit from what we call behavioral intervention. So let me speak to that just briefly. So if you look up online sleep hygiene or best sleep habits, it helps us control the variables over which we have control, which can help us increase the quality of our sleep. For example, exercising during the daytime can help improve sleep at night. Avoiding liquids before bed. Avoiding caffeine, even up to 8 hours before bed. Avoiding alcohol before going to sleep. Avoiding video-based technology within 30 minutes of going to bed. And importantly, as another example, having consistent sleep routines. All of these factors are what we call behavioral type interventions, and this can help facilitate sleep as well. So again, a common challenge for a lot of people with Parkinson's and common challenge for many who don't have Parkinson's. But identifying what the cause of the sleep disturbance is and then tailoring the intervention to those challenges can be very helpful.
Thank you, Dr. Wertheimer. I think you listed about 12 different great suggestions to help with sleep hygiene. That should be very helpful. The next question comes from Robert. I have heard my doctor talk about apathy. What is apathy, and what is the impact on the person with Parkinson's disease and their family?
Robert, what a marvelous question. Apathy can be a conundrum for many people. It can be a little bit difficult to understand. So let's first define it. So apathy is described as a lack of interest, a lack of motivation. Some even say that there's a lack of enthusiasm. So as clinical providers, We often hear from significant others, gosh, my spouse or family member has a personality change. So individuals with apathy can have difficulties initiating or even showing interest in activities, or even activities they used to find interesting, or even in their relationships that they find themselves in. So let me pause for a minute and say it's very important to differentiate apathy from depression. Apathy may be a symptom of depression, but apathy can be distinctly different from depression. And apathy may be misunderstood because some people see that masked face that's come with Parkinson's and think that people are not interested. So it's important to understand the differences there. So it can be helpful to talk to your movement disorder doctor or another PD specialist to help untangle and explain these concepts. But Robert, come back to the question. Apathy can be difficult for people with Parkinson's, and sometimes it can be even more difficult for the family members, because apathy can adversely impact effective management of our PD symptoms, since apathetic individuals are less inclined to engage in self-care, to engage in activities. Sometimes they don't manage their medications because they don't initiate that management. Sometimes they don't exercise, which we know is very important in our general health, physical and psychological. So if, again, trying to understand the role of apathy in one's life and how it impacts their life, talking to an individual, a specialist in Parkinson's, can be very helpful in guiding appropriate intervention. Again, thanks for asking such an important question.
I think that's one of the most misunderstood symptoms in Parkinson's, and he was so right the way he asked the question because it has a very large impact on the family. Thank you so much, Dr. Wertheimer.
Thank you.